I've got four, I've got Stuart, I've got Emma, and Emma. Okay, we're good to go. We've got four. So I'm delighted to welcome, we've got Rhoda Radalla, who's the Director of Nursing Excellence and Magnet Recognition at the New York Presbyterian Hospital, who's going to talk to us about the Magnet scheme. We've got Dr. Emma Wadey, who's Deputy Director for Mental Health Nursing at NHS England. We've got Stuart Lowry, who's Service Development Director for NHS Professionals. And we've got Emma Westcott, who's Assistant Director, Strategy and Insight at the Nursing and Midwifery Council. So I'm going to welcome Rhoda to come up and speak first. Thank you.
Thank you, Steve. Hello, everyone. It's great to be here in London. I'm Rhoda Radalla, the Director of Nursing Excellence and Magnet Recognition from New York Presbyterian, all the way from New York. So, this is so exciting to me, well-being conversation, and we will be focusing on that during this session. So my role is focused on magnet recognition. Any idea on what comes to mind with magnet and how that came about? So magnet is the gold standard of nursing excellence. It's a designation by the American Nurses Credentialing Center, and it dates back in the 1980s and actually started because of a massive nursing shortage in the United States. And the American Nurses Association commissioned a study. It's a national study looking into why are some hospitals retaining nurses better than others, right? So there was a national study through the American Academy of Nursing, and what came out of that study, they found out that there were common characteristics, common themes that hospitals shared who tend to attract nurses. So now when you hear the word magnet recognition, that's how it came about, right? Magnet attracts nurses and attracts top talent. And with that, there are outcomes that were being tracked, which comes down to everything that we are wanting to see in our patients. It's all avoiding complications, med errors, and all of that, but also having the best teamwork within the team. So I'm mentioning magnet. This is the magnet scheme, and I would love to see some of you at my table, is that well-being, okay, in the new standards of magnet, starting 2023, well-being will be a new requirement that organizations will need to meet to be able to attain magnet status. So I think to me that speaks volumes and strongly so much of what we need to do, right? So for the questions that we'll be focusing on, although I'm saying magnet scheme, but it's also really looking at frameworks and models of excellence, how we can support nurses by supporting their well-being. So the questions that I have would be, first is how do your leaders advocate for organizational resources that support well-being? And many of you here are leaders, so I'm sure you're interested to talk about that. But also looking at all roles, right? All leadership roles. How chief nurses, chief executives, managers at the unit level, how are we all advocating for organizational resources that support well-being? At the baseline, okay, at the baseline, this was even before the pandemic, we know that there's increased work pressure. Nurses are exposed to patients experiencing pain, suffering, and trauma. But that's at the baseline. How much more, right? Add all the new climate that we're in now with post-pandemic. And there has been established relationship between nurses' ability to care for self and their ability to give the best possible care. So as leaders, we need to make sure we're thinking about that, and that's front and center of our conversations. And I've learned so much from today's discussions on how are we supporting recruitment, transition to practice? How are we threading that through in our leadership roles and leadership agenda, right? Are we integrating well-being into our strategic plan as an organization? Or are we integrating well-being into our nursing strategic plan? and even at the unit level? So that's the first question. The second is, what structures do you have in place for nurse well-being? In the US, in my world, so we have what we call a shared governance committee, specifically the R3 committee. And in my hospital, it was R4 because it was expanded. It is recruitment, retention, and recognition committee. And the fourth R, if you hear R4, is respect. But that is based on or anchored upon a shared governance model. If you're familiar with professional governance or shared decision-making or shared governance, it is nurses at the front line who are involved in direct care being part of those committees, and they are at the core of that committee. For example, so do you have structures like that? What other structures like well-being champions, well-being coaches, how are we putting them into our entire framework in the organization? How are we structuring our meetings? Do we have mindfulness minute before we start our meetings, before we start our huddle? So what are those opportunities that we can think about to support well-being throughout? The third question is, what measures do you have in place to track burnout among nurses? Or are you even tracking nurse burnout, right? So I know in conversations we have today, there's like the 369 mark in recruitment and check-ins. Are we integrating well-being in those check-ins? And what other things can we come up with? So I'd be very interested to hear about those conversations during our session today. So more to come later, and I will really look forward and be in the lookout for exemplars to highlight at the feedback session. Thank you.
Okay, thank you very much, Rhoda. And you join Rhoda on the red table. Next up is Emma Wading, who's the blue table.
Good afternoon, everybody, and I haven't come from anywhere as exciting as New York. So we're going to be talking about the role of professional nurse advocates. And for me, starting in role a couple of years ago now, at the beginning of the COVID pandemic, was really aware by looking and listening, more importantly, to colleagues and to colleagues in other countries that had previously experienced pandemics, that unless we look after our staff, we cannot look after patients. And actually, by nature of the roles, what we do in healthcare, although they are incredibly rewarding, every day we are exposed to trauma and to vulnerability and to pain. And this has a psychological impact on all of us, and it weighs a burden that we need to be able to manage and care for. But the way that we manage this and solve this is within ourselves. And what we needed to do was to create the conditions in which we can thrive as nurses in order to give the best care to our patients. And we know that one of the key indicators, the risk factors for burnout, for psychological ill health, actually for physical ill health, is when we feel we cannot give the best of ourselves and the best care to patients. And all of us felt like that during COVID, and probably still do, with this, the stretch on services and the increase in acuity and demand. So the role of professional nurse advocate was developed for nurses, by nurses, with nurses. It's a professional master's level leadership program which not only focuses on well-being but on creating the cultures for feeling well, being well, and supporting ourselves, our colleagues, and caring for patients. In 18 months, we have around 6,500 professional nurse advocates who are trained and working in every healthcare setting in England, through social care to general practice, acute, community and learning disability. But we need many more, and they need to be supported. So on our table, we want to explore how are the roles of professional nurse advocates, and specifically restorative clinical supervision, working in your organisation. What has the impact been, and how can we build on this?
Great, thank you, Emma. So that's the blue table, and that's talking about PNAs and how they can improve staff wellbeing. Next up is Stuart, who is the purple table.
Afternoon, everyone. My name is Stuart Lowry. I'm the Service Director for the NHS Professionals Academy. I just want to say, first and foremost, what a great day this has been so far. It's brilliant to see so many colleagues and also to listen to so many ideas and learn from those as well. So fantastic. At NHS Professionals, we have over 190,000 bank members registered with us. and every day they provide an intrinsic part of the service. We regularly engage with our bank members through surveys and qualitative conversations. And in a recent conversation, 70% of our bank members identified education and training opportunities as being fundamental to their role and to their career. So education and training is something that we take very seriously for our bank members, and we are delivering learning pathways and courses and learning interventions across the board to support the bank members in delivering services throughout the NHS. So if we recognise that education and training is a key element within the wellbeing agenda, then on the purple tables today, we have 3 key questions. The first is, if we do recognise that education and training is important, fundamentally, then what are the blockers? If we all agree with that, what stops us? And also, how can we remove those blockers? The second question is, if we recognise that education and training is important for all nurses and midwives as part of their continuous personal and professional development, then what areas or elements will have the most impact over the next 3 years? And the third and final area, and you'll have to forgive me here because these are new glasses and I can't see anything. So it's how can we actually engage those nurses and midwives to be part of the process? And I think that that's a key thing. I see it over here on the drawings. You know, how do we actually involve the nurses, make them stakeholders so that we can develop best practice, but also to develop really engaging and pragmatic learning programs. So come and join us on the purple tables. I'm supported by a superb group of colleagues from NHS professionals, so look forward to seeing you there.
Great, thank you, Stuart. So that's matching workforce expectation on CPD, purple tables, and I know how you feel about the glasses. So next up is Emma Westcott from the NMC.
Thanks very much, Stephen. So I think this is the first in-person event that I've done like this since the before times, and it's the first one that I haven't done in my slippers, which is a challenge, but it's really lovely to be here with so many of you and so many people on our register. So I'm looking forward to learning from you and working with you. So my session, and I was just interested to see how much people would be pitching, and would it be quite competitive up here, but it's been quite restrained so far, so I'm not going to change the tone. My session is going to be about leavers, and what we learn from leavers, and how we can stop the wrong sort of leaving, i.e. people who still want to be with us and work with us. So the NMC obviously has the biggest, I think it has the biggest professional register in the world. And it's getting bigger, and our next registration data report will be out in the next week or two if you want to track what's happening with leaving and joining in our professions. And contrary to some of the kind of narratives around this, at the moment leaving the register is pretty stable in terms of numbers, but of course demand is going up, and that's the kicker. So we want to talk about who's leaving and why in our session, and to talk about the differences and similarities across different groups of people in our professions. I'm really interested to hear from you if you're observing changes in patterns of leaving in your workforce where you are. We're seeing trends, certainly in terms of people we're recruiting to the NMC, about people being much more emphatic about their well-being, their mental health, the values base of the organisation, and those sorts of factors. Are they coming through for you as well? So we're going to draw on some of the leaver data that we have at the NMC, but we're also going to look at some of the material that's come out of think tanks and others, the Office for National Statistics, about wider labour force trends, because invariably they will impact on us if they aren't already in due course. And bearing in mind that there are positive and negative reasons for leaving, and we're not trying to stand in front of the exit. If it's time for people to go, if they want to go and they've got positive pull factors into another phase of life or another profession, that's great. It's the people who are experiencing the push factors that we want to think about. So we want to understand who's leaving and why, and we want to be able to segment those different groups of colleagues who might want to stay but don't feel able, and address their needs, and they will be different and various. And as Matthew Taylor, speaking this morning on the radio before he went to the CBI conference, said, it's about the quality of work. It's not just about the quantity of people available. It's got to be work that people want to do, that we all want to do. So my 3 questions will be, the first will be, what are you observing in terms of leaving patterns and trends, and what is concerning you where you are, if there are new patterns and trends? Second question will be, what steps are you taking and with what impact? So if you've already got interventions in play, it'd be really great for colleagues to hear from each other about that. And the third and final question is reflecting on what sort of data and insights you want locally in terms of provider level, regionally and nationally to help you address leaving and retain the workforce that you want. Thank you.
Thank you very much. So that's Emma Westcott is... Oops, that's fallen out again. Okay, never mind. Nothing to see here. Just try and put that back in. Oh, it's come out completely, so we'll just use this. Right, okay, so Emma Westcott is going to be on the green tables, and so that's about levers. Rhoda Radala is going to be talking about the magnet scheme and wellbeing, and that's the red tables. P&As with Emma Wadey is on the blue, and Stuart is talking about CPD on purple. So away you go. Cool. All right, everyone. Everyone is back, so we'll get ready for some feedback, if that's all right. So we're a bit short on time, so I'm going to go straight in and ask Rhoda, who is the red tables, to give her feedback. So Rhoda first.
Thank you. First, I would like to just acknowledge the red table. They had a very robust discussion. Woo! Right, so the first question that we answered is, how do your leaders advocate for organizational resources to support nurse well-being? And really rich discussion and ideas on this question. A common theme that I noted from those 4 papers that you filled out is advocate service. That came out as a huge theme, and also having a well-being team. Like by show of hands, who among you here in your institutions have a well-being team? Just curious. Ooh, okay. Who has well-being champions? Okay, so I think we are on the right track here, because that's the advice from the red table, right? Well-being team, well-being champions, but there's also a huge theme for making sure that there's access 24/7 for these services that we're providing. And as leaders, making sure that we are supporting that 24/7 access to those resources. There's also coffee trolley. In my institution, we have wellness carts that go around, and we have well-being coaches that go around using those wellness carts. And I think on the same theme, like we have the coffee trolley and other resources that you have. Catch-up sessions are also came up, but I think one key thing that we need to remember about that is that it needs to be structured, right? Catch-up sessions that are structured. And this is like on the first question, which is on the leader support, but you can see that when you're also thinking about the structures that they need to put in place, that we need to put in place to be able to support nurse well-being, there's overlap in all of the responses from the red table. So going to the next question, and then I'll merge them in a little while, is that the next question is, what structures do you have in place for nurse well-being? And some of them I already have mentioned, but also the P&A role, came up in many of the discussions, the nurse advocate role, and making sure that we are integrating all of this work into clinical supervision. So I don't know what themes came up from all your other discussions, but making sure that that's threaded through, and at the same time, I think hardwire it with policy. I think through all the 3 questions that we have is one common way to be able to achieve this and hardwire this is through policy, but it should not end there, right? We go back to the role of leaders. What's the role of leaders? Making sure that the policies are implemented and followed through. So that's the second question. And also there's a common one among the 4 tables is Schwartz rounds. Everyone familiar with Schwartz rounds, right? And other venues where there is reflection and conversations on everyone's experiences. Employee assistance program also came up, but also the bigger question is how are we implementing employee assistance programs and trying to make sure we link that to all the other framework or structures that we already have. And I am reminded of the answer to the first question earlier in the leader is linking it to the people's promise. So something that was new to me, but I think it's something that we can, revisit, linking it to well-being, evaluating that, what did we do well, what are our opportunities, again, all linked to staff well-being. And lastly, on the measures, right? What measures do you have in place to periodically track nurse well-being index? And the first question was, what is nurse well-being index? Like, how are we even measuring that, right? Are we even talking about that? So that's a place to start. So are we doing those check-ins as a group, individually? What are those processes that we have to be able to do that, or burnout? So the responses within the group show that we need to be paying attention to the staff survey results, and how are we analyzing them? What are the action plans aligned to well-being that we can gather from the staff survey results? Listening events and listening sessions came up. But again, the bigger question is the how of those listening events and listening sessions, right? And to me, I think what resonates to me, listening to all of this conversation is, I feel like, of course, this is like the England or the UK environment. And every time I come to Nursing Times and speak, there's just this feeling of like, wow, we have the same issues. We are talking of the same strategies, and we have the same vision and aspirations. And when we're talking about all these listening sessions and listening events, I think we need to do a deep dive of how can we really support nurse well-being. Recruitment and retention data, who is looking at that? That's, again, related to tracking the nurse well-being index. And when you're doing the surveys, is nurse well-being even specifically being asked? System approach was also an overall theme, regardless of the question, whether it was from the leadership question or the measures question. And there was one that I added to the question. There was a sub to the other questions that I had. So when we speak about well-being, we also, especially in my institution, we talk about workplace violence. So where are those conversations on workplace violence integrated into tracking nurse well-being? And it looks like there is already there are good processes and systems in place to be able to do this, right? You have good policies, there's good processes to be able to escalate them. There's good support when a violence incident happens. The well-being team gets, engaged and all of that. But I think the one lesson that I learned is to check these fragmented approaches that we're having and see how we can systematically address them. And I know we can have the whole afternoon talking about well-being, but that's to summarize our responses from the red table. Thank you.
Great, thank you very much, Rhoda, and to the red tables. And next we'll go for Emma Wadey, who is the blue tables.
Thank you. I know we don't have much time, and I just want to say a massive thank you to the blue tables. It was very animated conversations, and it was very difficult to try and capture all of those conversations, but there were some key points of learning, certainly for me to take back as the national lead for the programme. So the role of professional nurse advocates is still very, very new. This was only started in March 2021. And it's been something that we've been building, learning, taking feedback and adjusting right from the very start. One of the key questions I had at the beginning was, what is the role of P&A and restorative clinical supervision in your organisation? And actually the first learning point is still, despite this being nearly the whole of my world, although actually not my job for the last 18 months, not everybody knows what a professional nurse advocate is yet. And so there is still more work to be done in advocating and elevating and amplifying these roles and the benefits that they will bring not just to individuals but to their colleagues, their organisations and patients. We had many nurses on those tables that were professional nurse advocates, either on the programme about to, and we had conversations about making sure there's more consistency and support for nurses on those programmes of learning, bearing in mind that for many of the nurses actually who will put themselves forward or are asked to go on these programmes, some of them had not had any academic continual professional development, some of them for 10, 15, 20 years. Most had never had clinical supervision in their career, which is a travesty, in my opinion, as a mental health nurse, where it's core to our practice. And so I think probably there was a slight underestimation, probably on my perspective, on where we were on baseline and bringing people together collectively to really shift and transform culture. But actually, my goodness, we've got there with numbers, and now we need to sustain and embed it. And so we move the conversation on to how do we do that? How do we support those supporting others? How do we build an infrastructure around them that allows them to continue supporting their colleagues while supporting them? How do we think about going forward what the continual professional development might be for those P&As? We know we already have many examples of people retiring and returning to be professional nurse advocates, as well as private sector, dare I say, stealing some of our professional nurse advocates, although there are places available to the independent sector, just want to put that out there. But how do we really encourage support and embed this going forward? So this isn't just a fly-by-night idea, this is embedded and is something that is part of the core of what we do. We do have the policies already in place, but we also discussed where the critical element is. This is the P&A role actually in restorative clinical supervision is embedded within the NHS contract. It's not a nice to do, it's not a if you can, it's a must do, because looking after ourselves is a patient safety critical incident in the same way patient care is. It is written into safer staffing guidance, and it has pretty much been written into every policy written through NHS England from every department since 2021, and will continue to feature within our workforce plans, not just around wellbeing, but around making sure we provide excellent patient care, because the two are the same thing. So key points for me around how we sustain and embed this is support for the P&As, providing more consistency in approach, whether that be through the training and support available at the beginning, but also how that is understood and applied in practice, because we know that there are many organisations that are amazing. There are some that are new to the table and are still learning and building. And then going forward, how do we ensure that we build on those successes, learn from where it's not well, and continue to this transformation in the way that's already been started? And a big thank you to all of you who have supported this programme, taken on the training when for many of you were in the midst of what was our second wave when the critical care nurses and mental health nurses went first. And they took time that they didn't have to put others before them. And I just want to say a massive thank you to each and every one of you that have done that on top of everything else you're trying to do.
Great, thank you, Emma. And next up is, so that was the blue tables, talking about P&As, thank you. And next up is Stuart, who was the purple tables, which was CPD and workforce expectation on that.
Hello again. Firstly, to the purple tables, thank you so much. It was fantastic. The conversations were really energetic, lots and lots of good ideas, so thanks very much indeed. I certainly came out with a training need, which is how to manage time better when facilitating group conversations. We all looked at each other and went, can't believe it's gone past so quickly. Now, you're going to have to bear with me. In addition to the eye problem that I identified earlier on, I've now got the scroll in my book, which I'm probably going to have to go, what did I mean by that? But anyway, let's go through the questions one by one. In terms of what we saw as blockers, some of the key elements that came out, of course, time. We're all under pressure, we're all busy people, and how can we actually make the time for training? So there was a lot of conflicting priorities. There were curved balls of a clinical and non-clinical nature coming at us all the time. All these things need to be managed. And it was really, really interesting that some of us actually said that this is down to, kind of personal skills around actually the ability to say, no, I've got to prioritise. So, how do we prioritise? How do we manage our time better? How can we be more assertive in actually, kind of saying no to sometimes unfair demands or competing priorities? Another blocker was sometimes the lack of available courses, and it was seen, particularly in the table that I was involved with, that education and training opportunities had actually, been diminished over many years, and perhaps greater emphasis was placed on, the mandatory and compliance training, quite rightly. But, is there space for, other training, such as, non-clinical skills, for, personal development skills, etc., etc. A lot of people thought that, was it fair that we were asked to do education and training in our own time, for which perhaps we're not getting paid? And on our table, we certainly came up with the idea of, that contracted time for learning and developments. Now, once again, there's that 55 hours in the sort of the contract area, best practice. But is that actually really happening? And do we need to be more assertive to make that happen? There were other elements as well, and I am conscious of the time, around access to learning, particularly on things like night shifts. There were some limitations identified insofar as, sometimes education has to be paid back if you leave, and that actually is a risk for some people, puts them off. But we actually looked at some solutions. How can we actually take or make cases based on data and better data approaches. Board level sponsorship was particularly identified as important in terms of upping the education and training agenda within trusts and ICBs. And within our own sort of personal development programs, the development of influencing and persuasion skills. The second question, I'm just going to come up with one thing, which was, what would have the greatest impact? And I think that the next generation was the key consideration. It was thought that the army and the police go into schools, but actually it was more rare for nurses to go into schools. And particularly senior managers, who come from, black and ethnic minority groupings, can they be seen as role models for children, in schools? That was a key thing that came up. And the cadet program, I think, that is run by NHSE, how can we actually begin to promote that so that we get more children interested in providing healthcare services? There were all sorts of other great ideas around, do we fully evaluate training? Do people see the results of training and the benefits of training? And, the provision and communication of longer-term plans and learning pathways, rather than seeing education and training as being a rather transactional process. So once again, a huge thank you to the Purple Tables. Well done, great ideas, and hopefully you'll be able to take some of that learning away. Thank you.
Great, thank you, Stuart. And now, the Green Tables with our second Emma W.
Can't have too many MWs. So, as is now traditional, got to thank the tables. I tried standing in the middle of the four tables and rotating slowly, and it wasn't a great method of delivery. So, in the end, they just got on with it themselves. So, thanks very much for your patience. I will collect the flip charts that I haven't got yet. So, 3 questions. The first was about trends and themes in leaving. Are you seeing new trends and themes? Colleagues, by and large, said not necessarily new trends, but heightened experience of existing trends. And some colleagues who'd been around a bit longer said cyclical. We're back now where we were a few years ago on some of this stuff. Generational differences were surfacing, and new graduates coming through and what they want being different, what they're prepared to put up with being different. We talked a lot about bank. people electing to work on the bank because of wanting to establish choice and control over how they work and when they work, and in some cases also getting better reward that route, which obviously has a sort of wash back to your permanent staff, because it makes them feel like, well, if you can get flexible shifts going and decent pay going for these colleagues, why not the ones who've got the kind of organisational roles? We talked about whether colleagues in the profession want to recommend the profession, because obviously a lot of people come into nursing via role models and exemplars in their own family and friendship groups. And if people are feeling ground down, not necessarily being in a place to say, why don't you come and do this? And also that possibly the profession is quick to recognise the downsides, but perhaps without experience of other workplaces may forget some of the upsides and some of the great things that happen in nursing that don't happen in other jobs. So there's a lot of discussion about people's personal feelings about the work that they do. In terms of the interventions, I'll just mention a couple that were interesting. I mean, there was a lot of talk around trying to intervene upstream. You know, once people are leavers, it's too late. So, the phrase that obviously is familiar to some of you because it's cropped up more than once, but itchy feet conversations. Is there someone trusted, someone who, you can have that conversation with if things aren't right, but you don't necessarily want to leave? One of the tables was talking about the possibility of replacing people within ICS areas, for example, if they're not happy in their setting, but they are happy in their work. So the scope to do some of that sort of, bring in some of that agility locally and regionally. One controversial thing I read on one of the flip charts was we know that lots of people who are struggling to work are people with long-term conditions, people who are on waiting lists for NHS interventions themselves. So should we be able to push colleagues up the waiting lists? That was one of the things that people suggested. On the data and insight needs, people, a lot of people spontaneously said, we're always talking about why people leave. Why do people stay? What do we know about why people stay doing this work? It is tough. And there are, we need to know what the protective factors are. We need to know why some people are able to withstand the things that are difficult and benefit from the things that are really rewarding. And so that's an area I'll take back to NMC in terms of future surveys. We felt that probably we didn't hear enough about where nurses go next when they are going on to a different career and what they think, what are the contrasts that they experience, what are the ups and what are the downs of different work settings after nursing. And we talked a little bit about the opportunity for the ICS areas to really get under the skin of their local labour market dynamics, because we know those are hugely impactful on nursing decisions. We know that when the local labour market tightens, recruitment and retention in nursing goes up. It's very much a cause and effect area. So that was the sort of conversations we had on the tables. I think just from the NMC perspective, we are interested. Rhoda talked a bit about sort of health of the professions. We're quite interested in whether we can use our data on some kind of health index and to look at factors year on year, like the ratio of joiners to leavers, the direction of travel with average time on the register, whether things like revalidation deferrals are going up or down, are people struggling to revalidate more or less particular settings, particular groups. So trying to think about what that kind of dashboard might look like that we could report on year to play back to the sector some of the indicators of improvement or deterioration that might be of help to providers. So really glad to be part of the discussion. Sorry to colleagues I didn't get to speak to. And I didn't have enough handouts either, but my email's on the handout. I can send any out that you want. And do go on our website to have a look at our resources around registration and around leaving. Thanks very much.
Fantastic. So thanks again to our facilitators, two Emmas and Stuart and Rhoda. Now, something you may not know about Rhoda is that she's also written a book, okay? So The Essentials for Making the Most of Your Career in Nursing. And in the tea break, which is now happening, Rhoda is going to be outside on one of the stand-up, what do you call them? Where you kind of put things. Tables, yeah, high tables, that'll do. One of them, high table, to tell you about her book, no doubt with some copies as well. And before you go and come and have a look at our visual representation of how the day is coming along by Smart Up Visuals, because I think it's looking pretty fantastic. So see you back here at 3:15 for the final session. Thank you. Sessions, I should say.